Welcome guys to this recall discussion video of INI SS General Medicine paper. Now this is a recall based discussion from the student who have faced the exam. Therefore, there will be some sort of discrepancy between the question and the real option. But obviously most of the question will be similar. We can guess about it, right? So before going to deep into this discussion video, one thing that I would like to share about a program that we're launching, it is Harrison Revision. Okay, what is inside this Harrison Revision? It is a 6-month program starting for 10th May up to December 10th. So it is a total 6-month program where there will be 3 tests per week, and our aim is to complete the whole Harrison. Okay, complete whole of the Harrison in 6 months. Okay, in 6 months in the form of test and discussion. Okay, in the form of test and discussion. So it will be beneficial for those who are actually targeting NEET SS and want to complete the Harrison. Obviously, beside this, this is for the residents too, medicine residents, first year or second year or third year. You see, residents do not have time to read Harrison completely. They are busy at wards, busy at rounds, busy complete whole of their time in the hospital, only doing hospital work. So at the meantime, so that they can complete Harrison in the form of test and discussion format, easy format, go through each of the tables. We are devising this test and discussion 6-month course with weekly 3 tests. Okay, so who wants to join? Those who are eager to join this program can join through the link in the description. Our target are obviously NEET SS exam, then resident of first year, second year, third year, or or final year MBBS student, those who are preparing for board exam as well as the NEET PG to complete Harrison within the 6-month period. Okay. All right. So coming to the discussion. So first question for today is, so it is obviously recall based, so there should be some discrepancy expected between the question and which was asked in the real exam. So here it says 48-year-old obese male with type 2 diabetes mellitus is suspected to having metabolic associated fatty liver disease. Okay. And he has undergone FIB-4 score, which comes to be 1.1. According to current clinical practice guideline for the management of liver fibrosis, what is the next question? Now look, regarding FIB-4 scoring, this is a non-invasive tool, which is a rapid tool that can be used in an OPD basis for primary risk assessment for metabolic associated fatty liver disease or non-alcoholic fatty liver disease. Okay, NAFLD or MAFLD. Now, there are different tools actually for assessment of NASH or MFLD. So, what are those? It can be invasive. It can be invasive tools. Invasive one is liver biopsy only, or non-invasive tool. Non-invasive can be blood report based like 5-4. It can be as well as ALT-AST ratio, simple one, or it can be APRI index, or something like USG basis. USG basis is, for example, is a fibroscan or fibroelastography. It can be MRE, okay, MR elastography. All right, okay. Now, among this option, if you can see here, initiate antifibrotic therapy, no further follow-up. So, if you look into this FIB-4 scoring, what are the parameter in it? Parameter used in these are age, AST, platelet, and ALT. You see, steatohepatitis or MFLD or fatty liver disease, there is high chance when AST is more than ALT. Or from the here, you can write AST ALT ratio is more than 1. So you can see in this index, FIB-4 index, as the risk increases with increase in AST, risk increases with decrease in ALT, or the ratio gets more than 1. It is same thing only. Similarly, thrombocytopenia is a risk factor. Okay, thrombocytopenia is a risk factor that is usually seen. So what you can tell, thrombocytopenia or 1 by platelet. 1 by platelet, what does it mean? So it is thrombocytopenia is low platelet, right? So risk is directly proportional to 1 by platelet to risk of MFLD. Okay, risk of MFLD. So therefore here in this part, risk of fatty liver will obviously increase with increase in 1 by platelet, or it is inversely proportional to the platelet count. Okay, all right. As long as the platelet decreases, risk increases. That's what I have to say. Now you can see from this chart from Harrison, it is about how to go forward in primary care setting if there is risk of NASH or NMFLD. First of all, look on the FIB-4 scoring. So if FIB-4 scoring is more than 1.3, so value is more than 1.3, then what you need to do is reassess the FIB-4 periodically. Periodically, if within 1 to 2 years, if there is some comorbid condition like diabetes, hypertension, or some other conditions that can lead to metabolic associated fatty liver disease, if risk factor is present, you need to reassess within 1 to 2 years. If not expected, in such cases, you need to reassess every 2 to 3 years. Okay. Now, if FIB-4 score is coming very high, like 2.67, what you need to do at this point, you need to go for primary or secondary risk assessment in the form of MR angiography or liver biopsy. Okay. And obviously go for secondary risk assessment in such cases in when FIB-4 is coming more than 1.3. So how do you do secondary risk assessment? Like elastography. Elastography. Okay. Elastography. What you can see from here chat is that if based on the secondary risk assessment here, based on the secondary risk assessment, it is coming low risk, nothing to do, just follow up. If there is intermediate or high risk, at this point you need to consider for liver biopsy, or suspect cirrhosis and based on clinical and radiological finding. Okay, and go for particular management. Okay, now here what you can see in the question again. So FIB-4 score is 1.1, which is less than 1.3. The value that has been given to us. Okay, less than 1.3. So what you need to do, you don't need to consider anything here. Just only reassess. When to reassess? If the risk factor is present, if risk factor at least 2 present, then what you need to do reassess within 1 to 2 years. If risk factor is absent, at this point assess every 2 to 3 years. So what are the options? Initiate antifibrotic therapy? Never ever, based on only just report this primary risk assessment tool, you start antifibrotic therapy. No further follow-up, it is also never, because why never? There is type 2 diabetes mellitus as well as obesity, so risk is always there. Observation and repeat FIB-4 scoring every 1 to 2 years. Okay, this is the answer here. Observation and repeat FIB-4 scoring every 1 to 2 years. Now, urgent referral to LTP at this point, never, until and unless risk was very high, like more than 2.67, and you are going for secondary risk assessment in the form of MR elastography or liver biopsy, you never consider for liver transplant at this point of stage. Now, thing is that you might forget about this part about this FIB-4 scoring, and what value to remember as a significant. So, see, B is second letter. Consider I to be point, and F is the sixth letter. So if we read from this side, so it become 2.6. Okay, it is the second letter. It is the sixth letter. Sixth letter. Okay. So FIB-4 scoring more than 2.6 is very much significant, and more than 1.3, that is half of the FIB-4 scoring, which is significant. At this point, you need to go for reassessment. More than 2.6 is secondary assessment. Secondary assessment. And more than 1.3 is reassessment. Okay. Okay. Let's move to the second question. In severe ARDS, which of the following is the best current guideline based management therapy? Okay. So if you see directly from the Harrison here, there is a evidence based recommendation for ARDS therapy. So what does it suggest? Here, Here there are recommendation A, B, C, and D. So A is the one which is strong recommendation, very strong recommendation based on RCT. Okay, A is the one which is strong recommendation based on the RCT. B is which is recommended based on clinical trials or defined investigation, but clinical data is there, but this clinical data is limited. Is limited. Okay, it is B. Now, what is C here? C here refers recommended based on only alternative or intermediate evidence. D means harmful or not recommended. Not recommended. Okay. So here you can see properly this in this table, Harrison based table. Glucocorticoid treatment routinely is not recommended. Surfactant replacement and other anti-inflammatory therapy like ketoconazole, PG1, and NSAIDs are not recommended. Only special cases like glucocorticoid treatment can be done for COVID-associated ARDS. Glucocorticoid therapy can be considered. Okay, not in routine cases. Among these, which one is strongly recommended? Only one thing is strongly recommended, that is low tidal volume. So low tidal volume around 6 to 8 ml per kg of predicted body weight is the one which is advised in case of ARDS. But why? Why? Why 6 to 8 ml per kg of predicted body weight? Why this is followed? So you see in ARDS there is often dense consolidation. There is often dense consolidation resulting into normal area. So you can see there is dense consolidated trunk, so resulting into decrease in the normal lung tissue viable for aeration or respiration to take place. So large portion of the lung are collapsed, fluid filled or consolidated. So this part, as you can see here, will not participate in any form of ventilation. So what is happening here? Only small part of the lung is taking part, and we can compare this part to be in adult population event to compare to the lung of a baby, or we call it to be lung of baby or baby lung. So normal tidal volume formula or calculation of tidal volume will not work at this place because total portion of the lung available for us for ventilation is very less. Therefore, consider it to be baby lung and ventilate according to the baby lung or 5 to 6 years of age group. So give a low tidal volume is the approach which is used in case of ARDS, and it is equal to level A of evidence. Therefore, answer in this question will be obviously it will be low tidal volume based ventilation, that is option A. Okay, now coming to the third question. A 45-year-old male presents with exertional dyspnea. Okay, now he has got wide pulse pressure, bounding pulse, and an eyelid diastolic decrease in the murmur. So it is already giveaway answer. It is nothing but aortic regurgitation. Just to explain things, so why there is exertional dyspnea in aortic regurgitation? So in aortic regurgitation, left ventricular is always in the state of volume overload. Okay, so there is right atrium, right ventricle, left atrium, and left ventricle. Okay, so what happens? What happens in case of aortic regurgitation? During systole and diastole, in diastole mainly, there is incomplete relaxation resulting into more of a volume load in left ventricle, resulting into left ventricular volume overload. Now, all of this lead will state of LV, ultimately lead into state of LV dilatation. So, left ventricular dilatation in turn will lead into heart failure, and symptom of exertional dyspnea. Okay. Now coming to the part what are the other options, other pointers given in the question? So he has white pulse pressure. So why there is white pulse pressure? Now, in systole, in case of aortic regurgitation, the stroke volume will be more because of the excess of the LV cavity diameter and excess of the content in the left ventricle. So, during systolic change, the stroke volume will increase. So, in systole, stroke volume will increase. Stroke volume will increase, and in diastole, excess of the blood goes back because of incomplete closure of aortic valve, semilunar valve. Excess of the blood goes back into the LV cavity, resulting into runoff from LV. So when you see in such patients, systolic BP will be raised and diastolic BP will be decreased, resulting into state of something which is known as white pulse pressure. So you can often find patient with BP of 140 by 40 or 150 by 30 in such cases. Now, what is meant by bounding pulse? Bounding pulse is nothing but what you know from age-old age is water hammer pulse. Water hammer pulse. What is it? So here there is rapid upstroke followed by collapse, which is nothing but the hallmark of aortic regurgitation. And the murmur here is decrescendo murmur. Decrescendo murmur, along with regurgitation, the murmur intensity decreases. So if you plot the diagram, so it is the decrescendo murmur. So it is a highly diastolic decrescendo murmur seen in the left sternal border. Okay, it is usually high pitched and blowing in nature. So clearly, answer here will be aortic regurgitation. That is the option B. Now, why other are false? Why MR is false? In MRs, what happened is you will find pansystolic murmur, pansystolic murmur. Okay, and where it is found? It is found usually in the apex that radiates up to the axilla. Okay. In TR is also there is pansystolic murmur, but this pansystolic murmur, the question point that is asked usually in the question is that in the question stem is that murmur intensity increases with inspiration. So there in tricuspid regurgitation murmur, the intensity will increase with inspiration, which is also called to be Carvallo's sign. Carvallo's sign. What about mitral stenosis? Mitral stenosis will be mid-diastolic rumbling murmur with some form of opening snap, and there will be no bounding pulse, no white pulse pressure. So it is a mid-diastolic murmur plus opening snap. Okay. So these are the different type of murmur in different valvular diseases. Okay. So here answer is option B, that is aortic regurgitation. Now coming to the next question. So what is said here? So there is a 26-year-old male who is presenting with acute onset of hemoptysis, progressive dyspnea, and decreased urine output for 3 days. Okay, so there is symptom of pulmonary system as well as symptom of renal system here accompanying together. There is no rash or joint involvement. In urine, there is RBC cast present, dysmorphic RBC present, chest X-ray suggestive of bilateral diffuse alveolar infiltrate. So it is nothing but a case of pulmonorenal syndrome. And in pulmonary renal syndrome, what are the pulmonary complaint given? Hemoptysis along with dyspnea, along with bilateral diffuse alveolar infiltrate, nothing but it is a diffuse alveolar hemorrhage. In renal, what is the symptom that is given? In renal, there is RBC cast present, so most likely this is nothing but a glomerulonephritis. Glomerulonephritis. Okay. So how do you manage this case? So, so most likely this case which we are dealing with is most likely nothing but anti-GBM disease, which is called to be Goodpasture syndrome. Okay. Now, management is in such cases, whenever there is lung involvement is present and diffuse alveolar hemorrhage is present, you need to quickly act on it. Quickly act on it so that the main reason behind it is anti-GBM antibody, circulating anti-glomerular basement antibody. So anti-GBM antibody is in excess in circulation, which cause the symptom. So we are main aims to quickly act on it and remove this anti-GBM antibody. How you can quickly act on it? By only plasma pheresis or plex. Okay, plex is the only way to remove them very quickly. So what else? What else you can do? You need to do is to reduce the inflammation. How to reduce the inflammation? With the help of steroid. So treatment, and this in this case, whenever there is lung involvement, there is diffuse alveolar hemorrhage, is always high dose steroid, pulse steroid along with plasma exchange. Okay. Now, it is a life saving in case of alveolar hemorrhage. So, why others are false? High dose steroid plus cyclosporine. Okay, this is also used, but it is not the first line in case of diffuse alveolar hemorrhage when it is a life threatening condition. So, in acute alveolar hemorrhage, Plex is mandatory. Cyclophosphamide is done, is given, but it is added later on. It is later on, given later on. Okay. Now, regarding baricitinib and plasma exchange. So, baricitinib is used mainly in baricitinib is used mainly in COVID related CRS. So, what is meant by CRS? CRS is cytokine related storm. Okay, so it is used mainly in COVID related cytokine storm, not in this case. Steroid alone? No, obviously not here. Steroid alone will not be used. Okay, so as you can see in Harrison, it also mentions in Goodpasture disease. In Goodpasture disease, who presents with hemoptysis should be treated for their lung hemorrhage as it responds to plex or plasma paresis. Okay, so patients with Goodpasture disease with hemoptysis should be treated with plasma paresis only. Okay. Now coming to the next question. So what does it say here? It says 32-year-old male is presenting with blurring of vision, and this blurring of vision there is along with there is diplopia. So there is blurring of vision and diplopia. On examination on attempting left gaze, the right eye fails to adduct, left eye abducts with nystagmus. What is the most likely lesion? So, so this is a case of internuclear ophthalmoplegia due to most likely a right MLF lesion. So let me explain it first. So what you can see, this is left side, this is right side. Okay. On attempting left gaze, the right eye fails to adduct, left eye abducts. So left eye is able to abduct and right eye fails to adduct, it remains in the central zone. So other point is not given. Other point is not given. We don't know what is happening in the primary cage. So we can consider to be normal in such case. And even if you rule out as other option is not given at this point, what you know, medial rectus medial rectus of right side is not working in hand with lateral rectus of left side. So what we can also say, so left side lateral rectus is supplied by which cranial nerve? It is by sixth cranial nerve. Sixth cranial nerve of left side. Medial rectus of right side is supplied by which cranial nerve? It is by third cranial nerve of right side. So what we can say from here is that coordination between left sixth nerve and right third nerve is lost. So what is this coordination? It is nothing but MLF or medial longitudinal fasciculus, which stays near the right side. Okay, and it is usually at the level of the nucleus. That's why we call it to be internuclear ophthalmoplegia. So this is the effect of internuclear ophthalmoplegia resulting into into similar presentation, and it is due to right MLF lesion. Okay. So what is supposed to happen in right oculomotor nerve palsy? Option A. So there will be loss of adduction and convergence will also lose. And what additional point will be there in history? There will be ptosis in history. Pupil will be dilated due to effect of the Edinger-Westphal nucleus. So there will be ptosis and dilated. What are the additional point that will be mentioned in history in case of right oculomotor nerve palsy? What will happen in left abducent nerve palsy? In left abducent nerve palsy, eyes will not be abducted. Eyes will not be abducted in the left side. Okay. Right PRPF lesion. So what does PPRF parapental reticular formation results into? It results into horizontal gaze palsy. So both of the eye will not look into one side in case of PPRF lesion. Okay. Now, as you can see from this Harrison diagram itself, so what is given here? So this is the primary gaze. In primary gaze, primary position of the gaze, the eyes is in the normal. So in the first diagram, as you can see here, it is the primary gaze, eyes are normal. Okay. Now when patient tries to look in this side, in the right side, what is happening? What is happening? Right eye is able to abduct. Right eye is able to abduct, but left eye is not adducting. There is loss of adduction. Loss of adduction. Sometimes, due to this fact, there can be nystagmus in right eye too. Okay, there can be nystagmus in right eye too. Where is the defect? Defect is in the left side, MLF, or it is left INO. Okay, it is left INO. Left side INO. Even you can see in MRI at the nucleus of abducens, there is a defect. Okay, so it is internuclear ophthalmoplegia. Internuclear ophthalmoplegia. So what are the causes? So causes of this internuclear ophthalmoplegia, multiple sclerosis is the most common cause. All the tumor, stroke, trauma, or any brainstem process may be responsible. So most common cause is MS. Okay, MS is the most common. Then what can be other cause? Stroke can be another cause, trauma can be another cause, or brainstem disease can be other causes. Okay, brainstem disease can be other causes, but remember most common is multiple sclerosis. There is something known as 1.5 syndrome too, which is due to lesion of the MLF combined with the lesion of either abducens nucleus or the pyramidal pontine reticular formation of the same side. So INO plus sixth nerve involvement, sixth nerve, or PPRF of the same side is known as 1.5 syndrome. 1.5 syndrome. Okay. So answer here in this case is right MLF resulting into right-sided internuclear ophthalmoplegia. Okay. Now, coming to the next question, 62-year-old male presenting with syncope. Okay, so 62-year-old male is presenting with syncope, ECG showing alternating bundle branch block pattern. So, what is the most appropriate management? So, you see in ECG there is alternating BBB pattern. So, alternating BBB is nothing but infranodal block. But main important point here is that patient is having syncope. So, this infranodal block is symptomatic. Whatever the level is brought, whether it is infranodal or supranodal, if this is symptomatic at any point of time, most appropriate management is permanent pacemaker. Okay, so it is indicate disease. This alternating bundle branch prong. What does it mean? It is indicate disease that both the right and the left bundle branch are involved. So there is high chance this alternating bundle branch will can progress to complete heart block. Now in alternating bundle branch block, it is a class 1 indication for pacing, especially with syncope, which is symptomatic conduction disease. So it becomes urgency, very urgency to go for it. Beta blocker will obviously worsen the condition not given in case of bradycardia or symptomatic syncope. ICD is indicated when there is ventricular arrhythmia or ejection fraction is less than 35%. Okay, so ICD is indicated for it. It is not only for isolated conduction block. It is along with if there is low ejection fraction is present, we consider for ICD. Observation obviously never, because it is a high risk condition. High risk of sudden cardiac death is there. Therefore, it is not chosen in such case. Now you can see Harrison also mentioned whether it is AB block or synodal dysfunction, whatever the cause of bradycardia or bradyarrhythmia is, that in all of the cases, pacing is the fast line. Until and unless there is something known as Mobitz type 1 block with no symptom, asymptomatic causes, and there is no other causes behind it. In such cases, pacing will harm. In rest of the cases, fast line is permanent pacing. Permanent pacing. Same goes for sinus node dysfunction. If patient is symptomatic, so first question is confirm symptom and rule out the reversible causes. Now, if answer is yes and goal directed medical therapy has been done, in all of the cases, if you find symptom is correlating with the bradycardia, that is the symptom in the question given like syncope, which is correlating with bradycardia, first choice is permanent pacing. Okay. Only there is some specific condition when in patient with symptoms that are possibly attributable to sinus node dysfunction, a trial of oral theophylline can be given. So oral theophylline can be given trial even if there is no response at this point. At this point, permanent pacing is again indicated. In rest of all of the cases, pacing is first line. Pacing is first line. Okay, all right. Now coming to the next question, 24-year 24-year-old female presents with recurrent unprovoked brief episode of abnormal sensory experience. Okay, so there is recurrent unprovoked brief onset of sensory experience. She describes a sudden smell of burning rubber with no motor activity. She remains fully aware and able to recall the event. According to International League Against Epilepsy classification of 2017, the seizure is best classified as. Now, these symptoms are very much localized, and you can localize this to olfactory area. Okay, olfactory area where it is located, it can be in the temporal lobe, most likely. Now, patient awareness is there, awareness is intact. So how do you know awareness is intact? Because memory is there, memory intact, and no less of awareness. So it is a focal aware seizure. So focal onset seizure with preserved awareness is the cause, and it is non-motor, it is sensory, olfactory area is involved, so it is focal onset non-motor seizure with preserved awareness. Okay, now if you want some more bit of neuroanatomical correlation in this question, which is very important here, so it is a form of olfactory hallucination, right? There is sudden smell of burning rubber, so it suggests there is involvement of temporal lobe. And which part of the temporal lobe? It can be uncus, it can be uncus. Okay, uncus, and we call this to be uncinate fits. Only patient feeling about the smell, nothing else. Okay, now in old terminology we used to call it to simple partial seizure, now we call it to be focal seizure. Okay, okay, all right. Now you can see here in this classification of seizure, current classification of seizure according to International League Against Awareness against epilepsy, what we classify into focal onset, generalized onset, and unknown onset. Now, in focal onset can be further described as having intact or impaired awareness, motor or non-motor, and evolve from focal to bilateral tonic-clonic seizure can be there. So, focal is again divided into intact awareness or impaired awareness. Focal is again subdivided into motor or non-motor onset. Okay. So in this question which we have, burning rubber smell, most likely uncinate fate is nothing but intact awareness along with non-motor onset seizure. Okay, all right. Now coming to the next question. Congenital adrenal hyperplasia is most commonly due to mutation in which of the following genes? That is, it accounts for 90 to 95% case. So congenital adrenal hyperplasia, even if you remember from your basic, most common cause is 21 alpha hydroxylase deficiency. So even if you remember only this fact and look into this question, only option D is matching with 21 hydroxylase, so it is CYP21A2. Now some quick fact if I want to tell, so enzyme deficient here is 21 alpha hydroxylase. What it lead to? It lead to decrease in cortisol. Decrease in cortisol plus minus decrease in aldosterone will be there. Aldosterone will be there, decrease in aldosterone. So what will the effect? Along with there is increase in androgen. So what will the effect? So as there is decrease in aldosterone, there will be salt wasting. Salt wasting symptom will be there in such cases. So it will be salt wasting. What will happen additional? There will be hypotension. Due to increase in androgen, what will be there? There will be virilization, early virilization in females. Okay, so this will be seen. This will be seen in case of 24 alpha hydroxylase deficiency. Regarding other option, HSD 3B1. So 3 beta HSD deficiency, it is a rare of the rarest of the format, and what is seen here, it is all the steroid decreases. So glucocorticoid, mineralocorticoid, as well as androgen. decreases. Remember 3 for all 3. So decrease in all the type of steroid. So what will happen? As glucocorticoid and mineralocorticoid is decreasing, again there will be salt wasting and hypertension. There will be chances of hypoglycemia, and due to decrease in androgen, there will be ambiguous genitalia. There will be ambiguous genitalia. Okay, all right. Now regarding CYP11B1, so here cortisol only decreases and aldosterone will increase, so there will be hypertension along with hypokalemia. Okay, hypertension along with hypokalemia. Regarding CYP17, there is decrease in cortisol along with androgen and with increase in mineralocorticoid. So there will be hypertension along with sexual infantilism. Okay. Okay, so hypertension along with virilization is 11 beta hydroxylase deficiency, 11 beta hydroxylase deficiency, and hypertension along with sexual infantilism is seen in 17 alpha hydroxylase deficiency. So what happens in 17 alpha hydroxylase? 17 alpha hydroxylase, there is decrease in cortisol, decrease in androgen, increase in mineralocorticoid. Okay. And what happens in L11B1? There is decrease in cortisol only. What happens in 3 beta 1? Here they are decreasing all three cortisol, androgen, and mineralocorticoid. What happens in 21 alpha hydroxylase deficiency? There is decrease in cortisol, decrease in mineralocorticoid. So decrease in cortisol, decrease in mineralocorticoid or aldosterone, and increase in androgen. What will be symptom in 17 alpha hydroxylase deficiency? So decrease cortisol, increase in mineralocorticoid. Increase in mineralocorticoid result into hypertension plus hypokalemia. Decrease in androgen, what will it to lead to? So decrease in androgen will lead to sexual infantilism. Okay, so again here there is increase in mineralocorticoid 11 beta 1, so there will be hypertension plus hypokalemia. Androgen is normal, so as androgen is normal, there will be increased in virilization. In 3 beta 1, all of the three decreases, so there will be ambiguous genitalia, plus hypotension. There will be in 21 alpha hydroxylase deficiency, there is decrease in mineralocorticoid, so there will be hypotension, increase in androgen, so there will be virilization. Okay, all right. So that's all about congenital adrenal hyperplasia. Now coming to next question. So this is question from sensitivity specific topic, screening test topic. So here a new screening test was evaluated in 100 individual known to have disease. So this is the person who have disease. So in the form of the screening test, what we call it to be? It is true positive plus false negative. It is the total population here is 100 who are having disease. Okay. Test correctly identified 90 of them as positive. So TP or total positive is 90. So what does this represent? So it represents TP. It represents TP by TP plus FN. So it is 90 by 100. That is 90%. So what does it represent? Here represent is the rate of true positivity. What is meant by rate of true positivity? It is nothing but sensitivity. Okay. So here this is nothing but sensitivity. Okay. Now as you can see from this Harrison table too. So what is meant by true positive rate? In true positive rate, it is TP by true positive plus false negative. False negative rate is Fn by TP plus TP by Fn. So false negative rate, it is 1 minus true positive. So true negative rate. True negative rate is true negative by true negative plus false positive. It is specificity. And false positive rate is false positive by true negative plus positive. That is 1 minus true negative rate. Okay. Now, thing is that in question, what you need to remember, in such question, what you need to remember. So if question mention about true positive and among the total positive, it is nothing but sensitivity. If it about mention the who do not have disease or normal people population, then it is most likely talking about specificity. Accuracy is about overall correctness, so there is no specific to disease group, it is in the population group rather. Accuracy. Positive predictability is the probability that positive test truly has disease. It depends on prevalence. Okay, it depends on prevalence. All right. Now coming to the next question. So 72-year-old male who, with a known coronary artery disease and stable angina on evaluation is diagnosed with de novo hypothyroidism. All right. Now here here you can see TSH is 45, TSH 45, free T4 is low, TSH is also coming to be reached, so it is hypothyroidism. How are you going to manage this case? So what is the most appropriate next step in management? Now, now here obviously I would like to start levothyroxine at 12.5 to 25 microgram per day and titrate every 1 to 2 months. Why so? Why so? Look, this patient is elderly and along with there is coronary artery disease. And and in this case I would like to slow titrate the thyroxine level. Because why? Because in presence of coronary artery disease, if you give suddenly increase the thyroxine level, it will increase the heart rate. It will increase myocardial oxygen demand. All of these can precipitate MI and angina as well as arrhythmia. Therefore, in cardiac diseases, it's always better to start slow and go slow. Okay, start at low and go slow. Okay, so what is the initial approach? Initial approach is start at 12.5 to 25 microgram per day, titrate every 4 to 6 weeks. Target is to normalize the TSH. So what is target? Target to treat is TSH to be normal. Okay, now, why other options are wrong? If you look in the option A, that is IB levothyroxine bolus. So, indication of IB levothyroxine bolus is myxedema, coma only, nothing else. It is not a symptom of myxedema, coma here. You never give to prevent myxedema, coma. You give only when there is myxedema, coma is there. This patient is more or less stable, so it is not indicated. Full replacement, if there is no comorbid condition, particularly cardiac comorbid condition, I would consider full replacement. Usually in the young, healthy patient, we go for full replacement. Okay. 50 to 100 microgram, obviously in young non-elderly population we can consider for 50 to 100 microgram, not here. Even Harrison says, you can see here, adult patient under 60 without evidence of heart disease. Okay, key is where heart disease is absent. Only in such cases you can start on 50 to 100 microgram of levothyroxine daily, not in other cases. So therefore answer here is to start levothyroxine at 12.5 to 25 microgram per day and titrate every 1 to 2 months. Okay, so it is also mentioned here. Okay, titrate accordingly. Now coming to the next question. So here what you can see here, a 72-year-old presents with in the emergency department with sudden onset right-sided weakness. There is 1 hour duration. On examination, right-sided hemiplegia is present. Okay, so right-sided weakness, right-sided hemiplegia has been confirmed in the examination. There is expressive aphasia, gaze deviation to the left side, most likely vascular territory. Now, most of you I have heard that made mistake in it, considered to be brainstem because there is left side gaze deviation as well as right hemiplegia, but it is not the case here. You see, gaze deviation in the left side means problem is in the right side actually. Left sided muscle are working very well. So where it is problem, as there is right hemiplegia, the problem is obviously in the left sided hemisphere, likely. And left hemisphere is the dominant hemisphere. In dominant hemisphere is the part which controls the Broca's area, and it is responsible for aphasia. Okay, so it strongly suggests the left MCA territory. Now, why there is gaze deviation towards left? You see, frontal eye field controls the gaze. So, right frontal eye field defect, gaze deviation will be in the left side. Left frontal eye field defect, gaze deviation will be in the right side. So here problem is in the right side. So right frontal eye field is involved, resulting into gaze deviation towards the left. Okay. So final diagnosis is left hemisphere involvement with Broca's area involvement. Broca's area involvement most likely parietal lobe involvement. So it's most likely left MCA territory involvement. Okay. Why not right MCA? Right MCA will cause left hemiplegia and there will be no aphasia in case of right MCA territory. Why not PCA? PCA does not present like it. PCA will present with vomiting, something of a stroke, and in which there will be ophthalmological involvement in the form of homonymous hemianopia. Why not brainstem? In brainstem involvement, there is crossed finding. Crossed hemiplegia is seen in case of brainstem involvement. Okay. Okay. Now, coming to the next question, which of the following virus shows red self-tropism? So it is one of the easiest question from this paper. So parvovirus B19 actually has a strong affinity for erythroid precursor in the bone marrow because of its P antigen which is present on RBC membrane precursor. This parvovirus P19 has a great affinity towards it, and that's why there is chance of aplastic crisis more often in hemolytic anemia or sickle cell condition or pure red cell aplasia, mainly in immunocompromised with parvovirus B19 infection. Now, even if you see Harrison mentioned in the first page of this chapter of parvovirus B19, the first line is that B19B virus belongs to the genus Erythroparvovirus and it is so named due to its narrow tropism. To erythrocyte precursor in the bone marrow. Okay. So answer here is nothing but parvovirus B19. All right. Okay. Now coming to the next question. So what does this question says? It says a 48-year-old male present with sigmoid colon growth biopsy confirmed it to be adenocarcinoma. All right. Now molecular testing was done which showed high microsatellite instability or MSIH. MSIH. Okay. Now MSIH tumor or tumors with high microsatellite instability arise from deficient mismatch repair. So what is the defect here? Usually defect here is deficient in the mismatch repair. What will it lead to? It will lead to high tumor mutational burden. So there is high tumor mutational burden and it result into production of numerous of antigens. Now these antigens make the tumor highly, so it increases antigen, and we as this is a new antigen, we call it to be neoantigen. This neoantigen in MSIH tumor or microsatellite instability high tumors which has high tumor mutational burden makes it to be immunogenic. Immunogenic. So in such cases, this immunogenic cells has direct benefits shown with, with drugs like immune checkpoint inhibitors. So drugs like immune checkpoint inhibitors like pembrolizumab or nivolumab. Okay. So pembrolizumab or nivolumab are the immune checkpoint inhibitors which is high affinity for it. Okay. All right. All right. So this is the thing that we want to discuss here. So if you look into the option, the tumor is likely to be highly responsive to immune checkpoint inhibitor. Option A is the correct answer here. So if you look into the other option, molecular profile is strongly associated with KRAS mutation. So actually, this immune checkpoint inhibitor responsive one, which are due to MSIH instability, are more associated with BRAF V600E. Okay, these are associated with more of BRAF V600E rather than the KRAS. In fact, many MSIH tumor are KRAS wild in nature, so they do not show any sort of association. Okay, KRAS mutation in it. Now, MSIH status indicate poor prognosis compared to microsatellite stable tumor in early stages. Now, regarding early stages, early stages colon cancer, these do have a better prognosis compared to microsatellite stable tumors. Obviously, these are debatable topic, not specific answer is there regarding this, but we don't know. It can have poor prognosis and bad prognosis too, but in early stages, MSIH status indicates that poor prognosis is false. It is rather better prognosis because in early stages there are medication available which can control the disease. Adjuvant chemotherapy with 5-fluorouracil monotherapy is the gold standard for stage 2 MSIH. No, you have already said that 5-fluorouracil resistance is usually seen. They have no benefit in stage 2 patient and no benefit from adjuvant 5-fluorouracil monotherapy, and therefore first choice here is only immune checkpoint inhibitor like pembrolizumab or nivolumab. Even Harrison mentioned patient with MSIH high colon cancer should be treated with checkpoint inhibitor as initial treatment only. Okay. Okay. And for the vast majority with MSS, microsatellite stable colorectal adenocarcinoma, who are not candidate for complete remission or metastatic disease, treatment with systemic chemotherapy is associated with marked improvement in overall survival compared with palliative care alone. Okay. So MSS colorectal cancer, first choice here will be obviously surgery. When surgery is contraindicated, at this point we go for palliative care in the form of chemotherapy. Chemotherapy in the form of 5-fluorouracil. In MSI high, microsatellite high, what we go for? We go for immune checkpoint inhibitor. Okay. And in early stage, they have rather better prognosis. Now, one important point I like to discuss here. Can you see the age group? It is 48-year-old male. So these are a little bit of an earlier onset, not in the earlier, obviously in the middle age group, but it is more of a little bit of earlier onset for development of colon cancer, right? So in younger patient, MSI age or microsatellite instability often points toward a syndromic approach, and that syndrome that I want to discuss here is known as Lynch syndrome. Okay. So Lynch syndrome. So in Lynch syndrome, there is germline mutation in MLH1, MSH2, MSH2, MSH6, and PMS2. Okay. MLH1, MSH2, MSH6, and PMS2 in the germline mutation that can be seen in case of Lynch syndrome. All right. Okay. Now, coming to the next question. So, what is given here? A 36-year-old male with history of Crohn's disease involving the terminal ileum undergoes ileal resection. So, 2 years later, he presented with acute colicky flank pain. So, what kind of stone is more commonly? They are developing, renal stone they are developing. Now, in a healthy individual, dietary oxalate, so oxalate which is coming from the diet, I'm talking about this in the state of health, right? So, this dietary oxalate will bind to calcium, where do they find? In the intestinal lumen, and resulting into insoluble complex, calcium oxalate complex, that is excreted out in fecal matter. Okay, through the gut, fecal matter through the gut. Now what happens is Crohn's disease, which has undergone ileal reaction, terminal ileal reaction, ileum dissection. So what will happen in them? They will have, due to ileum is the part where fat soluble fat is absorbed. So the fat soluble one component cannot be seen. Fat soluble vitamin deficiency will be there in the form of A, D, K, E deficiency, and there will be fat malabsorption. Okay, this ileal reduction result into short bowel syndrome like picture, where there is bile acid pool depleted and subsequent malabsorption of fat, and this unabsorbed fatty acid binds in the colon to the calcium, resulting into saponification. So what is the effect? So since the calcium is low, why low? In the circulation it is low because it is busy binding to the fat, so it is no longer available for to bind with the oxalate. So it leave a high concentration of free soluble oxalate in the circulation, and this free oxalate goes into blood stream to the kidney, and the kidney they bind with the calcium, urinary calcium, resulting into calcium oxalate formation, stone formation in the kidney. Okay. So this is the pathophysiological basis of this concept. So oxalate, dietary oxalate in normal circumstances in the state of health is gets bound to the calcium. Why it gets bound to the calcium in the intestine, in the intestinal lumen, resulting in formation of calcium oxalate stone, which is excreted in the fecal matter in the form of calcium oxalate. Now, in ileal resection, in case of Crohn's disease, there is fat malabsorption. Why fat malabsorption? Because there is depleted bile acid pool and fat malabsorption. There is obviously chances of deficiency of fat soluble vitamin as well in the form of A, D, K, E deficiency, and and this excess of fatty acid now is going to the colon and binding to the calcium, resulting into saponification. Now, what is happening to the total calcium? Total calcium, it is busy binding with the fat. Now, this total calcium cannot bind with oxalate anymore. Oxalate is going to circulation from the gut. Now, this oxalate will be absorbed in the circulation. It will go into the kidneys, and in the kidneys, what will it lead to? It will bind to the calcium of the urinary calcium, resulting into calcium oxalate stone formation. So there are high rates of formation of calcium oxalate stone. Okay. So what is the long-term complication? So long-term complication is obviously calcium oxalate stone formation in such cases. Okay. Now coming to the next question. So this is the last question that I'm going to discuss in today. So 28-year-old patient with known history of sickle cell anemia and chronic analgesic abuse presents with acute colicky flank pain, gross hematuria, and certain rise in serum creatinine. So what is the condition? So you see in kidney there is something we call to be vasa recta. Okay, there is something we call to be vasa recta. In this vasa recta are located in the medullary interstitium, in the renal medulla. So in renal medulla there is something we call to be vasa recta. Vasa recta. Okay. So in this vasa recta, they usually have low oxygen tension. Partial pressure of oxygen is low in vasa recta compared to the general circulation. Then high osmolality. Osmolality is high. Osmolality high, and this there is acidic pH or low pH is there. Every three factor together will lead to high chance of sickling. High chance of sickling of RBC in the small vessel supplying the papillae, and it will result into microinfarct formation. It will result into microinfarct formation, and eventually this microinfarct will lead to eventual necrosis. Will lead to eventual necrosis. Okay. Now, moreover, person taking analgesic, particularly NSAID. What does NSAID causes? NSAID causes inhibits the prostaglandin synthesis. Inhibits the prostaglandin synthesis. What usually prostaglandin causes at the level of afferent and efferent arterial, it results into afferent arterial dilatation. It is a potent vasodilator. It is a potent vasodilator at afferent arterial end. Arterial end. So when there is no potent vasodilation action in the afferent arterial end, it in particular patient, this due to absence vasodilation, there is more vasoconstriction, more decrease in partial pressure of oxygen, more increase in osmolality, and low pH condition. Low pH condition, all of this increases necrosis, and particularly why necrosis in the papillary places, in the renal papillae. So patient of sickle cell anemia along with chronic analgesic abuse have synergistic action which result into renal papillary renal papillary necrosis. Therefore, answer here is option B. Okay. So even if you see in the Harrison, it says in sickle cell nephropathy, there is high chance of papillary necrosis because of the ischemia due to sickling of red cell in the relatively hypoxemic and hypertonic medullary vasculature and present with gross hematuria and ureteric obstruction. So what are the causes? Causes are analgesic nephropathy, most common cause, followed by sickle cell nephropathy. Then diabetes with urinary tract infection is the one of the important cause, and prolonged NSAID use is obviously is a cause. So here A and B both are there. So that's why this is a condition of papillary necrosis. Now, if you want to remember the cause of papillary necrosis, you can remember with the form this mnemonic postcard. So, what are the causes of papillary necrosis? One of the important causes pyelonephritis. Pyelonephritis, that is UTI. It can acute pyelonephritis can lead to papillary necrosis. O is for obstruction. Obstruction of where? Of urinary tract. S is sickle cell. Sickle cell. Remember, sickle cell both disease and trait may result into such phenomena. Then T for T, remember tuberculosis. From C, remember cirrhosis. From A, remember to be analgesic abuse. Analgesic abuse. R is renal vein thrombosis. D is diabetes mellitus. So mnemonic for you is postcard. Okay. So that's all the mnemonic for to remember the cause of renal papillary necrosis. So that's all regarding the first part of discussion of INI-CET recall of this general medicine paper. Obviously, in the second part, we'll look into the other questions.